try and discuss and highlight here is when the new compound should be considered, what is the specific niche of each compound, and the most rational way of using them following that, and also what we can expect from some of the drugs in the pipeline. This has more or less been shown before, that the resistance phenotype is the result of an interplay of mechanisms where porin mutations definitely play an important role in modulating the total phenotype that we see, and also, for instance, things like hyperproduction of beta-lactamases. We will also, I think, see that a number of other mechanisms may be ultimately selected, which have been less common, but which might now result from many of the new drugs being stable against many of these mechanisms. And then we might actually start seeing novel resistance mechanisms as well. So in very short about Enterobacterialis and the activity versus the mechanism of resistance for all of these novel compounds that are already on the market. All of them have activity against ESBL, AMP-C, all of them except ceftolozane tazo. With regards to KPC, this can be inhibited by all of them. Possibly meropenem-vaborbactam should be the preferred agent. It has some PK/PD advantages and possibly lower selection of resistance, although that can also probably be disputed. Ceftolozane tazo has no activity against KPC. For MBLs, we can see that only cefidrochol has activity. And for OXA48 producers, we can see ceftazidime avibactam and cefidrochol being the ones with activity, but also meropenem-vaborbactam can be active. This is, however, not due to an effect of vaborbactam, but rather because it's meropenem in high exposure. So you could achieve the exact same thing if you gave meropenem alone 2 gram × 3 with extended infusion. With regards to OXA48, there is a tendency for ceftazidime AV to be maybe a preferred agent. The reason for this being that ceftazidime is not hydrolyzed by OXA48. And if these isolates are ceftazidime resistant, it's because they also have an ESBL, which you will then successfully inhibit with avibactam. So this is indeed a quite interesting option for treatment if you are encountering OXA48 infections. One could debate, as I said initially, whether meropenem-vaborbactam is preferable to Cas-Avi in KPC infections. There are concerns and also examples that emergence of resistance during therapy can occur, and this can be related both to porin loss and also the expression levels of the beta-lactamase enzymes. There are some data to suggest that development of resistance is more common with ceftazidime AV, but there is also data to suggest that from Italy, for instance, in bloodstream infections, that development of meropenem-vaborbactam resistance is also fairly common. So we should anticipate that resistance to both of them could develop, and there is so far lacking comparison with imipenem-relebactam. With cefidrochol, we know it's stable against all the enzymes, and this is partly a compound that's taken up by iron transporters in a Trojan horse style, where it's and the bacteria are of course very dependent on having a proper iron transport to be able to be viable and have a good fitness level. So that's why if you have defects in the iron transport system, it should affect the bacterial fitness, although there are maybe auxiliary iron transport systems, and this could present a possible mechanism of resistance. What we see is, however, that as long as the drug is getting in, it's usually very active. It has a number of side chains that actually contributes to the beta-lactamases finding it very hard to break down the compound. So maybe the main issue with cefiderocol is whether it always can get into the cell. There are some examples of in vivo emergence of cefiderocol resistance, and this was due to loss of function of TON-B dependent receptors needed for cefiderocol uptake. And in this case, there was also heteroresistance present prior to the exposure to cefiderocol, as visualized by disk diffusion, where you could see tiny colonies in the zone. So there were some indications that this could be a problem. We will see whether the increased usage of cefiderocol will lead to more such findings, and also how virulent these isolates prove to be, since they have, after all, a very important mechanism which is gone in terms of their potential virulence if they are unable to properly take up iron. I also mentioned about OXA48 and that ceftazidime AV should potentially be preferred, and this is as said because the ceftazidime is not affected by OXA48 hydrolysis. So essentially this is more about counteracting the effects of the usually present concomitant CTXM enzyme, and that you can easily deal with ceftazidime AV. So this might be a better option than meropenem-vaborbactam. You don't need meropenem-vaborbactam, then you might actually just as well use meropenem in high dose. Cefiderocol could be used, but there is no clear advantage over ceftazidime AV, and also some potential concerns, which I will review very soon. With Pseudomonas, we can summarize and say that we have ceftolozane tazobactam, which is quite active against and stable against many chromosomal mechanisms of resistance. Potentially, ceftazidime avibactam is a little bit better if you have class A carbapenemases, which are very rare though in Pseudomonas, and unless you have them, it doesn't offer much useful activity. So perhaps if you find yourself in Brazil or something, it might be an advantage. And on the other hand, ceftolozane tazobactam might tend to be slightly more stable against many AMP-C mechanisms. The most interesting is, however, that imipenem-relebactam is, contrary to imipenem alone, very stable against all of these mechanisms except for MBL. So the one that retains most activity against chromosomally resistant Pseudomonas is imipenem-relebactam, and I suppose you could say that is the greatness of this drug. Not so many other features, but in this feature, the drug is pretty unique. Cefiderocol, on the other hand, is also stable against MBL, as explained before, that has an even broader range of activity. And this is just some example of how imipenem-relebactam is restoring the activity to imipenem when adding relebactam, and this pertains also to many strains even with porin loss, and this is because relebactam is extremely efficient in inhibiting AMP-C, which makes Pseudomonas hypersusceptible to this compound, essentially, or to imipenem, since AMP-C is dealt with. You can see some low-level resistance in the form of penicillin binding protein changes, and a high-level resistance is usually always connected with metallo-beta-lactamases. And this is just an example of how some AMP-C changes can affect ceftazidime AV and ceftolozane tazobactam. As you can see here, some of these AMP-C changes can increase the MICs for ceftolozane tazo and ceftazidime AV, where imipenem-relebactam remains very low. And this is an interesting feature of this compound, and basically the only advantage of the compound as compared to others. This is just some more on the mechanistics of this, with single-step mutations occurring in chromosomal AMP-C. So both of these are stable to hyperproduction of AMP-C, but if you have a combination of hyperproduction and you have additionally configuration changes in the AMP-C itself. It might cause resistance to ceftazidime AV and ceftolozane tazo, but not to imipenem and relebactam. It's possible that this might also be associated, partly at least, with too low dose or the use in outside of indications. With Acinetobacter, the new agents usually do not offer a lot. In case you have some rare class A carbapentamases, you might see some useful activity with meropenem and birbactam, but those are fairly rare. Basically, this is mostly about the fact that you have cefidrochol covering all of the enzymes seen in Acinetobacter, but there is also another interesting feature in avibactam, in fact, inhibiting class D carbapentamases. So theoretically, you could give ampicillin sulbactam plus ceftazidime avibactam, which is theoretically feasible, where you would have the active compounds would then be sulbactam and avibactam. So you would not really need ceftazidime and ampicillin, but the others two could combine and produce useful activity, but you could also get that from cefidrochol. This is just some slides showing that with sulbactam alone, many of the carbapentamases, the class D carbapentamases, come for resistant to sulbactam alone, but you reverse this resistance if you add avibactam. If you add relebactam to sulbactam, there is a very low difference. So it's the combination of sulbactam with avibactam that is of most interest in this regard. There are now also some international guidelines. The Infectious Disease Society of America have guidelines, and ESCMID have a process ongoing with this. And for carbapenemase producing Enterobacterialis, all of these options are mentioned for urinary tract focus, but cefidrochol is warned against outside of the urinary tract because of one trial where it has higher all-cause mortality than the comparators, which is called best available therapy. With KPC, they recommend ceftazidime AV, meropenem, birbactam, and imipenem, relebactam, without really making a difference between those. And for OXA48, they recommend ceftazidime AV. For MBL, either ceftazidime AV plus estrionam or cefidrochol. And this is, in fact, the combination I will briefly describe soon, which is where you utilize the fact that estrionam is not hydrolyzed by metallo-beta-lactamases, and when you add avibactam to that, it's so that will inhibit other enzymes that usually comprise the problem and can lead to estrionam resistance through other mechanisms. Ceftazidime is not important in this regard, so the really interesting combination is estrionam plus AV, but that's not clinically available. So if you want to kind of make it yourself, this is the combination you need to give, or you can give cefidrochol. They also recommend in difficult to treat Pseudomonas, ceftolozane tazo, ceftazidime AV, or imipenem, relebactam, as I said, or cefidrochol if urinary focus, and also consider it to be given even in the case that you face metallo-beta-lactamases. There are some caveats, I would say, about cefidrochol and whether it's true that that we should be concerned about using it. I think we have to consider that UCAST has a more conservative breakpoint than CLSI, and some of the all-cause mortality increases could also be down to low-level cefidrochol non-susceptibility, if you like. So I think that has to be carefully analyzed. I wouldn't necessarily say that these recommendations of being very careful with cefidrochol outside the urinary tract is something I would endorse, but that's what the IDSA has stated so far. And for ESCMID, we do not know yet what will be in those guidelines. I promised I would also say something about the pipeline. And estrionam avibactam is being developed by Pfizer. We already have the possibility of using the combination Cas-Avi plus estrionam. and it's expected that it will be similar to giving the new compound, although not entirely confirmed. And this one is being assessed in phase 3 studies versus best available therapy for treatment of various infection types caused by MBL producing gram-negatives. And they are using molecular testing, and the study is expected to end in July 2022. And they also have a trial for treatment where they compare Aztreonam AV plus minus metronidazole versus meropenem plus minus colistin. So this will be quite interesting data to obtain, and this compound also, in theory, is useful not just against MBLs, but against essentially all of the different kinds, the OXA48s and the class A carbapenemases as well. We will see whether it becomes a super drug or whether there is development of resistance or whatever happens. Then to one of those with Acinetobacter activity, I told you already you might actually make sulbactam, avibactam yourself if you are a little bit innovative in the way you administer drugs. But there is also the option of waiting for this, where sulbactam is the active compound. We are used to seeing sulbactam as a beta-lactamase inhibitor, but in the case of Acinetobacter, it is the drug itself. Whereas durlobactam is an inhibitor that inhibits class D carbapenemases, perhaps a little bit more efficiently also than avibactam does. It's a novel DBO beta-lactamase inhibitor, so it's closely related to avibactam. And they have phase 3 studies ongoing, and we can see that the sulbactam durlobactam MIC is significantly reduced as compared to what we see for sulbactam alone, which is the blue bars. And this is an example from the ongoing phase 3 study where patients with documented or presumed Acinetobacter infections are either receiving sulbactam durlobactam plus imipenem or colistin plus imipenem. And they are looking into both efficacy and safety. And there is also a non-randomized study where they are studying sulbactam durlobactam plus imipenem to obtain additional safety and supportive efficacy to this previous trial. So with regards to AST, we have this diffusion available for all of these essentially except meropenem vaborbactam. Hopefully that one is to follow. And for all of the novel drugs, EDL are usually working very early with the company on developing this diffusion. And this is also why we can offer this diffusion very early, whereas this is not found in automated systems. And sometimes it's not from the outset available in commercial panels either. Cefiderocol has some special requirements in commercial BMD panels, but the most recent panels offer also Cefiderocol in there, which has also been tested by EDL. It's not known how the gradient tests perform, so this information we do not have. What is very important, and maybe my most important message of this talk, is that you need to do AST. You cannot just do some molecular assumptions. So this is an OXA48, so I can treat it in this way. This is an NDM, so I can treat it in that way. Rather, we need to very closely monitor this. If we are using these therapies, it's absolutely mandatory that we test also with the phenotypic method and that we follow closely up so that we avoid messing up many of these highly new useful drugs and are able to identify early problems. And we still have to learn how to use many of them optimally. Some concluding remarks. We do not know in high inoculum infections whether it would be desirable to combine drugs to reduce development of resistance. Might be something to look into. There is sometimes a lack of specific clinical trials for some indications, so we have to rely a bit on microbiology, PK/PD. Sometimes we are also such as with Cefiderocol, stating that we should be careful with this drug, potentially on a slightly unfair ground where we are considering off-label use and highly challenging infections where the prognosis is very poor, regardless of which drug you give, in fact. The knowledge about the mechanism of resistance is very useful, maybe not entirely necessary, but I think still useful, but it cannot replace phenotypic AST. And it's not known at present whether we should start combining some of these drugs. And I would also strongly encourage people to implement disk diffusion for these so that you don't delay the reporting by sending to a reference lab. It's absolutely fine to send to a reference lab so you can have MICs if you like also, but more importantly, test as early as possible with disk diffusion so that you will resolve quite a lot of them. That is my clear advice with this. And that is my final slide. And I think we are 2 minutes late here, but I do have one question as well, or actually 2 questions, Ulrik. So if we can, if I stop sharing, and then we have one question here. Let's see. So please vote on which of the following antimicrobials which has the best activity against Pseudomonas with chromosomal resistance mechanisms. I think we stop it there, maybe. And the correct answer here is imipenem relebactam. So at least the majority responded correct to this. It's also so that ceftazidime AV and ceftolozane taso are retaining a lot of activity against chromosomal resistance mechanisms, but imipenem relebactam even more so. And we can go to the next one. Which of the following inhibitors can inhibit OXA48? Yes, I think we can stop it there. And the correct answer here is avibactam. This is the only one out of these that can inhibit OXA48. So that's well done. I can see that meanwhile, we have received one question in the chat about how to test Estrionam avibactam if you would like to use it on an MBL. And this is a tricky one. Whether you, I suppose one thing you can do is place a Cas-Avi disc next to an Estrionam disc to see if there's some indications, but mostly this will be what you would like to do is, of course, to test the actual combination, but it is difficult to do that. So I think the best option I can think of is to place these discs next to each other to see if you have, obviously, if it's at the outset Estrionam susceptible, then it's fine. But if it's Estrionam resistant, you might then at least see that there is a tendency for avibactam to increase the zone size for Estrionam, in which case you may consider that this could work. It's not an optimal way of testing, so let's hope we will have some options, and that it will in the not so far future be included in the panels. Hopefully it's should not be a major issue to develop a Giske test for this. Yes, and that was also another one here. Will it be reliable to treat carbapenem producing organism with OXA48 like enzymes with meropenem 2 gram times 3 with prolonged infusion with an MIC of 1? I think definitely yes. I mean, many have been treated like this in meropenem vaborbactam trials. That seems to be working fine. And that's not due to vaborbactam. So if you are considering that, I think this is this can be a fair treatment option. But of course, if you are close to the break point, you still have to consider whether Cas-Avi might be, at least in a severe infection, maybe a safer option. But I don't think we have a head-to-head clinical comparison. So that's more based on what we know about the enzymes and the inhibition. Okay, that was 2 questions. I don't see more questions in the chat right now. So it seems like we are out of new questions for the time being.